Hello, and welcome to this week's episode of Ladies, Let's Talk About It. I'm your host, Dr. Denise Jagru. I'm a board-certified clinical specialist in women's health physical therapy. Today, we are going to be having a conversation with my friend, Dzifa Avalime. She is a women's health pharmacist. And every time I talk to her, I learn something because my only exposure before to pharmacists was like retail, like in CVS or Rite Aid.
Most people.
Or also being in the hospital setting, like seeing the delivery of medications to patients who were admitted, you know, but I didn't realize until I met you that like you like counsel patients, like any patient could just make an appointment with you and get counseling on like medications and different conditions and stuff, which is amazing. And I want to ask you more about that in just a little bit. But Dzifa and I also met in the same hospital system in Manhattan, and I've known her for a couple years, and I always ask her questions about like my meds and stuff, and she's so wonderful. And thank you so much for being here.
Thank you for having me.
Thank you. So I'm first going to ask you to explain like what a women's health pharmacist does, and then we're going to have a test. I'm going to test her, and I'm going to give her 10 true-false questions and ask about all types of things, and we're going to see how she does, even though she might have cheated a little bit because maybe I shared some of the questions with her. But go ahead and just tell our audience what a women's health pharmacist is. You don't just do women's health, right? You do.
I do. Now I do a couple things. So when I first started at the VA, I started out doing, actually, even before I got to our VA now, I started out doing geriatrics. And then at our facility, I now do geriatrics, women's health mostly. So majority women's health, and then partially geriatrics, and then also weight management. So that's what I also do.
Yeah, so much. So like patients come talk to you and you can recommend, you can prescribe, or you can...
Yep. So within the VA, I have a scope of practice. So there are different levels of pharmacist, I guess I would say. So you have your like traditional inpatient, outpatient pharmacist who you might see in the pharmacy, similar to like a regular hospital pharmacy or a Walgreens or CVS. And then you have like a clinical pharmacy specialist, lots of words, but basically that's kind of what I do. And because of that, I have a scope of practice where I kind of work with our like physicians and NPs and all of that. I can prescribe for diabetes, for fertility, for menopause, for osteoporosis, for cholesterol, kind of you name it, pretty much everything across the board, even some things like general pain and mental health as well, which obviously within our patient population is also really important. So yeah, I kind of have a wide scope of practice. Anything that is maybe over my head, I usually tend to defer to like our nurse practitioners or MDs, that maybe for somebody who might be more complicated, but we all work together, obviously, to make sure that we're doing like well-rounded care.
That's so amazing. And then to know like just all the interactions with all the drugs and like all the conditions and whatever, that is wild. That seems like a whole giant textbook of knowledge that like I don't know how you would have all in your head, but that's amazing. Well, and there's lots of resources that you can like consult for that, right?
Yeah. So I was gonna say too, kind of one of the funniest things, like when I was in pharmacy school, the first kind of class that we take is drug information, and our professors really hammer home that yes, pharmacists are the medication expert, but our job is to be the information finder. And because there's obviously so many medications, there's new ones coming out every day. There's interactions, there's brand names, there's generics, there's biosimilars, there's like medications that have to be compounded by a specialty pharmacist and things like that. So you can't possibly keep it all in your head at once. And so we kind of also have to be the experts in knowing where we can find reliable information.
Right. Because everyone's like a Google expert, right? And like looking for, and they think they know everything. So,
oh yeah.
But you're the one we need to trust. Okay, so I'm gonna dive into it. I'm gonna dive into our true false test for Dzifa. Okay, so question 1: true or false? Birth control pills can permanently affect your fertility.
Okay, so this one's a big one. It's false, obviously, but people tend to, they're really nervous. Like I get, especially for some of the younger patients, are like, I don't want to start any birth control because I'm really scared I won't be able to have kids later. And a lot of times that's not the case. And if there is fertility issues, there's usually maybe something underlying. Yeah. And so, definitely false.
False. What about like when patients stop using, like how long, I guess, and also when they start using, how long does it take the body to adjust to that?
So it kind of depends on the form of contraceptive. So for like something like an IUD, usually the onset of efficacy is pretty immediate. There's a specific kind of IUD that can even be placed for emergency contraception. And then you have like for the pill, I would say that usually is about 3 months. Generally, it kind of depends on the person, but also depends on, if you're forgetting to take a pill here and there. And so I would say about 3 months, then you have like the ring, you have the shot. So it really depends. But then the return to fertility aspect is usually pretty immediate. Most people tend to have a return to ovulation within a month for most of the contraceptives. And then for some people, it can take up to a year. But most people, after removing any sort of contraceptive, can get pregnant within 3 months of removal.
That's what I usually like kind of generically say to my patients, like, give it like 3-4 months.
Exactly.
Sounds like a good amount of time for like the body adjust. Yeah. That's what always happened for me as well. So do you recommend any one of those options over the other, or it's just kind of like what the person would be better at taking or tolerate?
I mean, it really depends. So for somebody who maybe is busier, has like a variable schedule, maybe forgets to take something oral, then, and they don't want to do like a more permanent or long-term option, then, well, not permanent, but more a longer-term option, I would say maybe the ring or maybe the Nexplanon, which, stays in for a shorter period of time, or doing the IUD if you want like 3 to 5 to 8 to 10 years of contraceptive. So yeah, there's kind of different stages. It really depends on what people are comfortable with. Like if they're comfortable just taking something oral, then there are tons of options for that. If they're okay with maybe inserting a ring, then that's also an option, or a patch. The patch is also an option. But if they are like, I just want something to set it and forget it, then maybe an IUD or an Nexplanon.
So how does the IUD work? Can you explain to our audience?
So depending on the IUD, so we have...
this is an intrauterine device.
Yes. So it kind of looks like a little T, and it gets implanted. There's copper ones, so if you want something non-hormonal, but then, so that releases copper ions, which kind of help block, the implantation of the sperm. And so then you also have... I'm trying to, like, my hands. Then you also have like the Mirena or Kylena. Starting to vogue. You got Mirena or Kylena, which does like a low dose of progesterone. So most oral contraceptives have both estrogen and progesterone to help with the different phases of the menstrual cycle. But you also have progesterone only for people who maybe have, we can go down a whole rabbit hole, but who maybe have like a higher risk of maybe like cancer, and we want to avoid adding external estrogen for those patients. So we maybe want to do just the progesterone only. And so those IUDs will emit a low dose of progesterone for a long period of time.
So like you say, it could be like 10 years or something. Like, so it has like medication in it, and it's just releasing it slowly over slowly. Like a decade.
Yeah.
Honestly, I've always just wondered like how, but that makes sense. It's just a low dose.
Yeah, and you always want to like check the string that it's there, that it hasn't moved, and also want to keep up with regular GYN appointments to make sure that it's like in the right spot. But
I know that I've had some patients have some like issues with like with the removal of it, or like it, something happening to it on the inside. But for the most part, it's generally a safe
generally
option.
I would say probably like, I think the numbers like maybe 1 to 3% of people maybe have like some sort of like it gets shifted into like the uterine wall, or but that's pretty rare.
It's rare.
Yeah.
Okay, that's good to know. Question 2, true or false? Antibiotics make birth control pills ineffective.
Okay, so this one is false, but with the asterisk.
Okay.
So there are some antibiotics that do render birth controls less effective. And so I pretty much tell all patients, while you're on the antibiotic, just make sure you're using a backup contraceptive just in case, because it really does depend. And it also depends on how long. And then also differs from maybe doing like an antifungal for like a yeast infection or something. So just kind of as a blanket thing, like just do a backup contraceptive while you're on it, and then usually for about a week or so after, and then yeah.
Okay. All right. So we got a little star
False with
asterisk.
a little caveat.
I'll take it.
So
I'll
like
take
false / a little true, but yeah.
Okay, I'll take it. I'll take it. And number 3, true or false? We were talking about this in another episode. Hormone therapy for menopause is unsafe and causes cancer for most women.
Another false one.
Right. Right.
Yeah.
And that we were talking about it, that it really came out of a poorly done study like 20 years ago that kind of just embedded itself, like the whole narrative of that embedded itself into society, and people just believe that estrogen causes cancer. And I was saying, like, right before this, I had got my hair done, and
well, it looks great.
And the lady was like, well, I'm not taking estrogen because my mom took it and it gave her cancer.
Yeah.
And I was like, wow, it's still like, even though very recently they removed the black
yes, they did.
black box label, right? Saying that, I mean, and that was monumental because that took a lot of work and effort from our, our clinicians and the ones that we know from our hospital system. They, they got this removed because it really was just the wrong messaging that got out from the study.
Yeah.
Because women who were not supposed to be in the study, who were very high risk for cancer, ended up developing cancer, and they were way, way, way post-menopausal, and like they would have probably developed cancer anyway. And so it kind of estrogen took the rap for it. And so like women for decades really didn't get the care that they needed because they were like, oh, well, I don't want to get cancer. I grew up thinking like estrogen causes cancer, right? And it's going to take a lot to reverse that 100%. Whole like narrative, I think, because it's like so in society. And I feel so bad that so many women have avoided and have not had a relief of symptoms that they've been experiencing. Boo. So I feel like now, women are approaching pharmacists and their GYNs for different types of care for like genitourinary symptoms, and it all like there's different ways to safely administer like low dosages, right, of estrogen, and it can be through like either creams if it's like a local issue, right, and like in the vaginal like urinary area, or it can be like through dermal patches, right? So what about like, do people take oral estrogen?
Yeah, so there's oral combinations of estrogen and progesterone, and there's oral combinations of progesterone only. There's oral estrogen, oral estrogen solo, but it kind of will depend on whether or not, like the risk for the patient of whether or not we also add on oral progesterone and not do a combination. Then there's like the vaginal tablets. There's also vaginal cream, ointment, patches. So yeah, so yes, people do take oral estrogen, but usually it's in combination with the progesterone
and it's all like low dosages.
Low dose.
It's not like you're, bombarding your system with high levels.
Correct. And it differs from like an oral contraceptive. So the dose that is studied for those combinations is not meant to do any sort of contraceptive action. It's to generally help the symptoms that of menopause or perimenopause.
Yeah, it's going to take a lot of work to convince people, otherwise, right?
100%.
Yeah. Okay, so number 4 basically has to do with what we just said. True or false? Vaginal estrogen carries the same risks as systemic hormone therapy, but like that's inherently wrong.
Exactly.
Because systemic isn't bad. There's safe ways to use it, right?
Yeah, and so with the vaginal estrogen, there are different kinds that are even generally the first line for somebody who maybe is having like some sort of atrophy or like issues with like the vaginal tissue during perimenopause and menopause is to do local estrogen. And so that's usually low dose. It kind of only stays in that area. Right. Then we have some options that are a little stronger that maybe some, I would say maybe like 10 or so % gets absorbed systemically, so the whole body. And so that may cause for some people, also the side effects there tend to be fairly low because it is still topical. And then some of the side effects, I would say, are just a little bit different for oral estrogen versus topical.
Yeah, and the side effects probably aren't going to be cancer, so you're going to be okay.
Correct. And but that's why like everybody kind of, even before thinking about medication, like thinking about, okay, what's your risk in general before starting anything, so that it's not, okay, this gave me this, right? It's, okay, what was my risk to begin with? What are the risk versus the benefit to maybe doing something hormonal? And if it's the best option, because for some people it might not be the best option. Maybe non-pharmacological options can suffice. Like,
So that leads us into question 5, which is true or false. If something is natural or herbal, it's automatically safer than prescription medication.
I'm going to go big false.
Big false?
Big false. So kind of
not just regular false.
Yeah, big false. So the thing that I am, I'm not a hater of supplements. I try to phrase this right every time I say something like this. I tell people all the time, like, I don't hate supplements. There has to be a way to monitor like how much you're getting, right? So if you ever look at a over-the-counter supplement, there's something called a USP label on some brands, and that just means it was studied by like the United States Pharmacopoeia, which is similar to like the FDA for regular medications. And that just means that whatever's on the bottle is what is in there, and it does what it is saying it's supposed to. So if it's like vitamin D, it's supposed to raise your vitamin D or maintain those levels. But with like a lot of third-party like mixtures, they tend to be studied by like an outside lab. They're not really verified by anything. You also don't know if there's additional fillers you could be allergic to. There's additional binders inside of the capsule or the powder or the tea or the pill that could cause other things. And so it really is sometimes trial and error of finding out which ones work. Like, there are a lot of studies, and I'm sure we're going to talk about it, but like cranberry or like red raspberry leaf for like relaxing the uterine lining or for helping with like UTIs and yeast infections. There are studies based on those, but also getting those supplements means you have to make sure you're getting them from a reputable source. And then, so things like that. So yeah.
Yeah, there's so many companies where they're just selling their own like concoctions online, and like with social media you can reach a lot of people.
The teas, and the powders,
and then all the celebrities who are like pushing different things, and I've fallen victim to things because like a celebrity is pushing it, and I'm like, 100%. Maybe they're but like it's crazy how much there is out there. I was even getting my hair done. The lady was like, I take beef organ supplement or something. And I was like, oh, okay. Where did you hear about that?
I know. I have to like, sometimes when like patients are like, oh, I started this and this, I have to like make sure to just like listen first before I'm like, okay, so what do you think each one does for you? And my proponent, I know people are always like, oh, well, you're the medication person. Like, you just want people to take meds. I'd actually rather you like, let's evaluate your diet, maybe. Like, let's maybe eat more whole foods. Because a lot of the times, the things that people are getting in supplements, you could just get in your diet.
And
you
some broccoli.
Yeah, eat
some cauliflower.
Eat a carrot, maybe. I don't think you need to take 8 vitamin C capsules. Maybe drink some orange juice. Have an orange, So things like that.
Yeah, these are good points. Such good points. What about like probiotics? Like, how do you feel about probiotics?
Okay, so probiotics are good for some people. So a lot of times there's like maybe an underlying factor for some people. They just are prone to maybe like yeast infections and things like that. So probiotics can be really helpful. But for some people who maybe have never had an issue, your diet could be okay and things like that. You maybe don't need a probiotic unless you're having some sort of issue. Yeah, a lot of it. And also sometimes it's the clothes, like the irritants that maybe like lotions or shampoos, like evaluating that first before introducing a probiotic. So I think they're good. They have a place. Same with supplements. It just really depends on the person.
Oh, I always thought it was like, oh, it's good for like a baseline just to like balance the gut microbiome and whatever. But I'm also listening to the commercials.
Yeah.
That's what they told me.
And it can be, but if you think about why, a lot of that is because the foods and the things that we tend to eat, and that is really
everything's so processed.
Exactly.
I mean, when I'm from Trinidad, and like when I go there, everything's so fresh, and like my gut reacts totally different. Like it's great because they don't have like all this processed food. They don't have like they mill their own flour, so I can eat bread without like blowing up. Like it's just it says something about.
That's why you always hear people. They're like, "Well, I went to Italy and I ate all this pasta, and my stomach was fine, but here I'm always in pain." And I'm like, well, there are reasons for that, unfortunately, but
and everything's so genetically modified, and it's not in its original form, and all of that nonsense. Okay, question 6.
Okay.
True or false? Should you wait? Well, this is silly. Should you wait until your period pain is severe before taking medication? And I have endometriosis, so like I had like debilitating pain since I was like 9, right? And like I was taking prescription stuff like pretty young, but I was like not functioning, And I'd be like, first of all, I thought everyone went through this, but they didn't because I was having like a severe like condition, and so I always tried to tough it out. I always you worry about addiction and stuff like that, but like. What do you say to that for like when you're having like terrible period pains and like or like how long should you wait before taking?
Well, I want to say too, same. I used to like miss school. Like I think by the time I started getting my period, I started like missing school because I would be on the floor like throwing up and in pain. So yeah, but also false. Don't wait till the very last minute. It's actually much better if you just start maybe even the day. It really, again, depends for the person, like maybe a day before or 2 days before. I have some patients where I'll tell them, okay, we might want to start, especially if you have a regular cycle, we can do like pre-treatment like 48 hours before to help relax, because something like an ibuprofen is anti-inflammatory. You want to help. And we only want to do it for a couple days, obviously, because those medications can be like tough on the gut lining and things like that. But we want to like help to relax. Yeah, the pain. Yeah, before you start feeling that like can't get up kind of pain.
I agree.
Yeah. Yep.
Question 7, true or false? Vaginal washes and douches help maintain vaginal health. Do people douche still?
People do.
Is it like recommended?
No.
Like, why do people do it? I feel like it's like I saw somebody
smell for like maybe extra. Like some people feel like they have a lot of discharge, but you were gonna say something. Sorry.
No, I was gonna say like I feel like I saw a lot of commercials like in the 80s, and like it was like like the thing. Like everybody needed it.
Well, even growing up, I remember like this is TMI, but like seeing in my like parents' bathroom, like seeing the like thing, and I was like, what is that for?
Yeah.
So, but it was so normal for people to do it until we realized like you're washing out all of the bacteria, not just the bad bacteria. So that's
Right. Yeah. So not great.
So no, false, big false, not good. Yeah. We don't want to douche or doing the washes. Like some of the pH washes can be okay, but like similar to a probiotic, really depends on the person. Like if you are constantly having, yeast infections and constantly having UTIs, we first want to evaluate like, okay, why is it happening? And if there's really nothing like causing it, then maybe, every now and again, maybe you're doing like a sport or something and you just want to kind of help to keep freshen up, then maybe like once a week or something, but every day, absolutely not. And then the douching is a big no, but the washes can be okay. It really just depends.
Okay. I want to know when it transferred from like vaginal health to being like an insult for like a jerky guy. Like when did a guy become a douchebag? Like when did that happen?
You know what? I don't know.
I want to look that up.
There has
Let
to
me
be
know
a
if any
story.
of you
Yeah,
know when that became an insult for like
there has to be like a story behind
male
that.
jerk.
Yeah, it's got to be a story behind it.
I'm gonna use Google.
Right.
Question 8. True or false? Does drinking cranberry, and I can answer this as well, but drinking cranberry juice cure a UTI?
Absolutely not. So again,
Big false.
Yeah, big false.
There were people, whenever patients say this to me, I'll be like, where did you hear that? And it's always like, my mom, my friend, my sister told me this. And I'm like, right, well, that is not the case anymore. And they used to think that cranberry would prevent the adherence of bacteria to the urethral tissues. And that is not the case anymore. And they've been doing studies to show that if anything, citrus of the
can make it worse.
Juice makes it worse. Makes it worse. And you really just need medication right? When you have an infection in your urethral tissues. I'm sorry I took that one away from you.
Oh, no. All good. That was great.
So
Exactly.
I wanted to jump in. Okay, number 9. True or false? Some common medications can affect libido.
Yes, that is true. Big true. Yeah.
Is there anyone that you would want to mention?
Antidepressants are a big one.
Right.
I know too, especially with like, I will say, I think there's been a couple studies that have come out recently that there's like a rise in prescribing because more people are seeking mental health help, which is great. But that means more people may be taking antidepressants like short term or even long term if necessary. But yeah, antidepressants are definitely a big one.
And birth control as well.
Birth control. Yeah. So those are probably the two biggest ones that I would say. Some people don't have any decrease. Some people do. It, again, really depends
on the person. And question 10, which we kind of talked about already. True or false? Pharmacists only dispense medication. They don't play a role in women's health care decision. And we know that's a big false.
Yes. Well, I actually haven't even been like, I haven't dispensed medication and I couldn't tell you how long. Like,
you're more the consulting and the
I pretty much am mostly patient facing unless I am covering to help in the outpatient pharmacy or inpatient pharmacy or, you know, like doing something at CVS or Walgreens or something. But yeah, pretty much. So
can you like have your own like business or you need to be within a hospital system?
So there are consulting pharmacists that maybe do like purely consulting by themselves for a lot of times it's for nursing homes and they will do like medication reviews. They will do adjustments, make sure that nursing homes and things are within like the Center for Medicaid and Medicare guidelines. Then but usually if you want to also prescribe, you have to be, if you're not within like a government system where you have your own scope of practice, you can have a collaborative practice. So a lot of pharmacists who also do what I do, but maybe work in like a private hospital tend to have a collaborative practice with a physician or an NP, and they can prescribe medications that way under the practitioner. And then there are certain states where pharmacists have prescribing capabilities for like birth control. So if you go to a CVS, you could say like, hey, I really want to get this birth control. The pharmacist can kind of do a little checklist with you, and then they have a collaborative practice. That pharmacy usually has a collaborative practice with a provider, and then they can maybe order you something as well.
Okay.
So yes, usually have to be in combination with like a general, like a practitioner, but can also have like different areas of pharmacy as well.
That's brilliant. I didn't know any of this. I really like grew up just thinking, you know, pharmacists like are just at CVS, you know, behind a counter where you don't get to talk to them.
Yeah,
you know?
And you think like they're just like back there counting
meds. Yeah,
but honestly, like even when I worked at CVS, like during pharmacy school, I didn't really count that much. Like when I was acting as like the pharmacy intern or as the like pharmacist in training, it's a lot of like reviewing to make sure the medication the order is correct,
Yeah.
or the scribble that you get from the from the doctor is correct, or that the amount and the indication is right, and then troubleshooting to make sure like, oh, do I need to call the office, or can I adjust? Can I switch something to a generic, or if something's out of stock, can I recommend some like a switch to something else? So yeah.
That's brilliant. Okay, so if there's one thing that you would want the audience to know or remember about medications and women's health, what would it be?
Particularly about women's health, I would say don't be scared to do the research, but then ask the questions, and don't be. I would say don't be scared to take something that could help you, but also means like weighing the risk versus the benefit. But one thing I want to tell everyone is also make sure you're being honest with your providers, because I find that as the pharmacist, a lot of times when I see patients, I'm like, hey, how is this medication? They're like, oh, I'm not taking that. And I'm like, did you tell your doctor? And they're like, no. And I'm like, well, they just went up on the dose because they maybe looked at your labs and they thought, it wasn't working. Did you tell them you didn't tell them you weren't taking it? And they're like, nah. So I think that plays a big part, just being honest, but also asking questions. Those are kind of the big things, not just for women's health, but
I can't tell you how many patients like either don't understand what they're taking, don't remember the name, and they're just popping pills. They don't know if they still need to be taking something. And just like, talking with your healthcare provider and like getting the information, writing down your questions, and having it all together in one place is really important.
And pharmacists are the most accessible healthcare professional. Like there's a CVS, a Walgreens, an independent pharmacy, a family-owned pharmacy, almost everywhere. You can pass by one. I promise you, pharmacists are totally okay with you coming up to ask them a random question about a medication. Now, they might have follow-up questions, obviously, because they maybe don't know your whole healthcare history, but they can at least point you in the right direction for information or give you follow-up questions to ask your providers. So, yeah.
Well, I don't know if they're all as friendly as you. You're nice. You're nice.
Thank you. I try.
Well, thank you so much for answering all these questions.
Thank you.
And
that was fun.
Giving us all this information. I so appreciate you coming here and just enlightening us with all your amazing knowledge. And I think it helped people understand that pharmacists are not just in CVS. Like you do so much. There's so many layers.
We don't just count pills, guys. I promise.
Which is probably, I don't know. Do pharmacists even count pills? Like, honestly, I feel like there's a machine or something.
Low. Yeah, it's pretty low on the totem pole of things. Like
they're highly skilled and they're accessible to you for your medical well-being.
Our lovely technicians tend to help with the pill counting and the machines and all of that. But most of the time your pharmacist is doing risk management.
Yeah, for sure. Well, thank you so much, Dzifa.
Thank you for having me.
Thank you for coming.
This is great.
Yeah, thank you for joining us today in our episode about pills and supplements and all kinds of stuff. And I hope you join next week for another episode of Ladies, Let's Talk About It.
Woo!
Love that you gave a woo at the end.
The studio audience, the in-studio audience.